Most of us would agree with this. This is more like making us aware of a situation, bringing up a point for discussion. Some of the questions may sound silly from all of us, but they're more to make it aware of why we're doing so. That it makes sense that if you've got such unstable symptoms, why a cath, why a stress test or a functional test? And one presumes he's on functional.
One quick point I'd like to make, I know we're all seniors here, is that we must remember that the functional testing is for patients stable angina. So NICE guidelines, any guidelines you read, they're for stable angina. This patient doesn't qualify as a patient of stable angina. So when you have unstable symptoms, you have ECG changes, you have imaging will suggest that there is something wrong. And in a patient who's 60 years old with risk factors, the likelihood is that you're going to find something, and therefore you have to go for the gold standard test, which is a coronary angiogram.
Yeah, but if he comes to me first time with this kind of symptoms and he was not on any medications at all, then I would definitely first put him on medication and see. I wouldn't be taking, if the patient is not on a medications, first time having symptoms, I shouldn't be, unless there's an acute coronary syndrome, I wouldn't be taking him to the cath lab directly.
Go by the patient's symptoms, ECG changes, and imaging findings that we have. Say, for example, this 60-year-old lady came in with class 2 angina, no medical therapy, ECG normal, echo normal. Yes, you go for functional testing. But not everything is normal.
So she has anteroseptal hypokinesia.
Yeah.
And we had a glimpse of the angio as well. So she definitely blocked her LED somewhere on the line.
Yeah.
It's very interesting that she blocked her LED and diagonal without any ECG changes, without any Q waves.
So she has
STT, no Q waves.
Not ST segment elevation. And one thing about this session, it will be more regarding tips and tricks of how to do DK crash. So if you proceed.
Jabbar Sahab, if I may, even Bashir Sahab felt we should go on to the DK crush and get on the tips and tricks. But this is about understanding the disease process. We need to understand everything. For example, I'd like to bring out this when to do a cath and when to just wait and observe. For example, a 2-week class 3 angina means it's unstable. There's thrombus. And if you wait and see, look, take this medication, come back 2 weeks. Now this is very fresh clot, which can get worse very quickly. My real question to all of you is, the guidelines are made keeping view the local facility available. Now in UK, if you had chest pain, more than likely an ambulance would get you in the hospital within 18 minutes. And this guy, suppose he's like 2 hours away in some interior Sindh or interior Punjab, he may take days to get back to where you are and then days to find a slot. There are no cath facilities within hours away from ordinary people. So do their guidelines apply to us? Number one, that's one question. The other is, we need to do a functional study. Now, look at the average pocket of a man. So this guy comes, we do we can say, okay, fine, take this medication, does he settle down or not? We allow him to settle down, then we do a thallium, then if we start talking about, look, you need to have, we look at courage and functional and ischemia trial. They've got everybody had in ischemia trial a CT scan. Now, do you end up with a CT scan for everybody, then go on to a cath in a selected few? But that's the real question that I think when we talk about guidelines, those guidelines to me, what applied in US, UK, and Europe doesn't apply to us. That's just a little comment. Any takers on that? Okay, let's see. Jabbar Sahab, if you could just describe, because you've got some shots.
Yes, her angio was done. This is the caudal view. We can see the LEDs subtotal, and the diagonal has got ostial severe disease.
So if you could describe that also, Rasab, so we're on all the same plan. Let's
So
run
this
this
was
again.
the RAO cranial view showing the LED subtotal. and probably there is some thrombus as well. So based on her history and this angiogram, how to plan it?
If you keep running the angiogram, so people can have their...
Okay, sir. This, I think this we will be... RCA was okay. RCA was disease-free and it was... Yeah, there was some feeling. There was some feeling.
Okay, question is, unstable angina, 2 week, you said there's probably thrombus. So is this right? I think there's definitely going to be thrombus. You have to keep thrombus in mind when you deal with this.
Yeah, she was admitted, she was already admitted in our hospital and was referred for CAT, and she was on full anticoagulation, antiplatelets, beta blocker, and nitrates.
Okay, okay, so you know there's occluded LED with the TIMI half antigrade. There's very critical, large diagonal on the side. How do you TIMI, Medina classify this? Anybody would want to Medina classify this? It is 011. Okay, 011? For all the classifications of bifurcation, I think it's the most useful. At least you all understand where they are. And so we know that there's enough evidence of ongoing chest pain. She is disabled, medical treatment is there. Recent episode, 011. How would people want to, what options do we have? Yeah, Jiva.
I think here the culprit is LED. We can see that it's a bifurcation 011. So we have to wire both LED and diagonal. And I think right over here we can see the diagonal is a fair size branch. We have to protect it. I think bifurcation strategy would be the choice. So provisionally the diagonal seems to get down. Then we'll be intervening LED. The bifurcation strategy, I think.
Okay. Bashir
Sir, before proceeding towards bifurcation study, we need to apply a definition criteria. In definition criteria, we have major and minor criteria. In this criteria, we need to rule out which is the side branch, what is the size of the side branch, and thrombus available, angulation, calcification. On the basis of this, we need to clarify which bifurcation setting to be done.
If you could just apply your definition to this, how would you apply it?
Sir, in this, if you apply, don't remember exactly the major or minor criteria, but on all of it. But keeping in view the angulation of a side branch and good size side branch dike, I will apply DK crush, sir. Because main LED, we have about more than 3 to 4 mm area in LED, proximal LED. So I will go for a DK crush.
Just out of curiosity, if you look at this, the disease, the side branch, is probably less than half a centimeter, about 5-6 millimeter. Can we keep it provisional?
No, sir. I'm talking about side branch is around 2.5 mm. Actually, I'm talking about.
I think it's 3. Look at the catheter. It's 6 French, so 2 millimeter. That's at least a 3, if not a 3.5 to me. I'm just, and once it opens, it may progress more. Look at the size of the circumflex. Just my option, it may or may not be there. Just being the devil's advocate, it might be 3.5. But why can't we keep it provisional? Just out of curiosity, having a.
One thing will depend on how our LED. While intervening LED, I think depends how good the flow we create in LED. Also depends on that. And if the procedure with LED is smooth, I think it qualifies for a bifurcation stenting. But if we get some issue while opening, fixing the LED, then provisional is also not out of question, sir. So what I want to say is depends on how LED behaves while fixing it, sir.
So you would proceed as a provisional? There's no right or wrong answer. It's a DK crush session, we fully understand, but there's no right and wrong in angioplasty. It's like playing what kind of shot. You remember Misbah, he went for a forward and then suddenly did a paddle sweep and got caught out. So there's no right or wrong. You can get out on a full toss, you can play a Yorker to a 4, whatever, but there's no right or wrong, just how somebody would approach. Yeah?
I think as Jalal mentioned, I would rather focus on getting LLE canalized first. That's the main artery, and you have to come back across the diagonal, which is quite sizable. And definitely I'll keep in mind, if it goes down, then I'll keep the provisional strategy in mind.
Sir, I will go for the... my name is Dr. Omar Farooq, working as assistant professor at RIC. I will go for the provisional stenting, and I will, since this diagonal is significant size, around 3 mm, but the disease at the ostium is less than 10 mm. I will wire the both LAD and diagonal, and I will go for the provisional. Since the angle is narrow, less than 90 degree, if the side branch is compromised during the procedure, then I will convert this single stent strategy into 2-stent strategy. What kind of strategy? Sir, reverse culotte, reverse crush culotte, sir. Yes, sir.
Tariq bhai? Just out of curiosity, how many of us are, it's very nice to say 2-stent strategy, but it needs a lot of skill, a lot of time, a lot of equipment. How many of us would really be very comfortable in doing a DK crush and coming out? It is not an easy procedure to do. It takes a toll on time, radiation, skill set. And if you have a lot of thrombus somewhere, to do multiple manipulations, it can be tricky. Why not a culotte? Why a DK crush? Yeah.
I personally, we all know that so far, the most, except left main, rest of the vessels, the data of 2-stent versus provisional hasn't shown much difference. I personally, unless like here, this is a much bigger size vessel, although the length at the ostium is short, I try to, most of the time, go for a provisional, especially it comes to diagonal and obtuse marginal, unless I'm concerned this is a large vessel, is going to close down and will be like supplying a major area in the of the LV. Like 2 or even 2.5 millimeter vessel, if unless it really closes down, and again, a lot of people say that your goal should be keep it open, especially the diagonal branches or obtuse minor. Left main obviously is different. We are not talking about left main. But here, as I think the length of the occlusion is, the stenosis is small, lesion is definitely there. There's a little bit haziness. There is a possibility when you balloon the left, the main artery, it might compromise. I will definitely wire. But provisional, if somebody tries to do that, I really don't think it's really going to be wrong. But again, whichever strategy you use for 2-stent strategy, you have to be, as you said, you have to be comfortable, whether it is DK crush, culotte, or tap, or whatever you do, and you should be doing it more frequently. Doctor?
Sir, in this bifurcation, the side branch ostium is definitely diseased, and it's a very short segment. I personally would like to go for provisional, but one thing I would definitely like to pre-treat this diagonal with just a 2 balloon to open up its, so that it doesn't totally lost after stenting the LAD. I don't know how other people practice regarding this, not to lose the side branch after stenting the main vessel. So just a pre-treat with nominal 2 balloon, nominal pressure to open it up enough that it doesn't get lost after stenting LAD.
I put 2 simple questions to all of you. One, this LED is totally blocked, which is infarcted. So this diagonal, this guy is actually living on his diagonal. There's some flow and that's keeping his entire wall going. So if that closes on us, it could be a real disaster. Number one. Number two, if you want to treat a side branch and you want to jail it, it's best not to pre-dilate. That's what teaching is. It's best not to pre-dilate because then there'll be dissections, and when you recross, there'll be problem recrossing. So that's the one aspect which I think we need to focus, not just focus, just keep in mind that if you pre-dilate this side branch, then recrossing may be an issue. I mean, for a guy with the skill set of Tariq Shafi Sabit, of course, we think Dr. Rosalie is just beyond the scope of this session. Yeah.
I just like to make a very small comment. I actually agree with what you're saying. So, you know, a lot of bifurcation work I do, most of the time I do provisional. And I would use a 7 French system. I put 2 wires down, balloon the LED, and after that I would use a 2512 balloon, go up to nominal in the diagonal. And if there is no recoil, and if there is no dissection, I would go provisional. However, if there is any dissection, any recoil, then I would initiate right from the word go, do a bifurcation strategy of my choice. That's how I would approach this case in my lab any day of the week.
Yeah, I'll agree with Umar and the other colleague, but I'll go one step ahead. I think I will dilate this diagonal with a 1-to-1 size, maybe 2.75, if not 2, NC balloon. That's what the guideline says, that if you really want to decide about whether you are going to stop here as a provisional or as bifurcation stenting, the approach should be to dilate this vessel with 1-to-1 balloon and with probably proper size NC balloon at nominal, and then see how does this vessel behave. And if that holds, then go ahead for provisional and then see that whether this, after stenting, this vessel gets compromised or not. I'll not dilate this. I'll definitely dilate this diagonal, and I'll not dilate it with 2 balloon. I will go with 1-to-1 size NC.
Yeah.
If cost is not the issue, we go provisionally, like in the beginning, we just pre-dilate the diagonal and we stent the main, and then we keep the diagonal. I think the segment is quite short, so wiring it won't be a difficult one because the angle is pretty easy in this case. Doing DCB at the last, finishing with DCB is also a good option, I think, in this case, avoiding the double layer and the bifurcation, the hazards of bifurcation in this case. So DCB for the diagonal, if cost is not the issue.
One thing I want to say, I agree with Dr. Omar, but as per the recommendation, unless the angle is very nasty or difficult, we should not dilate the side branch first. And there is some haziness as well. If we dilate, we don't know, sometimes angiographical it is very difficult to see this dissection unless we are doing the imaging. So then we may be in trouble if we pre-dilate it.
I don't think so. I think if there's a dissection in such a big diagonal, you won't miss it. And you know, I've done a lot of cases, and I'm sure others have as well, in which you initially go in, you think, oh, I have to use 2 stents. And when you gently pre-dilate, as Professor Saqib Shafi said, with a 1-to-1 balloon, NC balloon, at nominal pressure, you'd be surprised. You get away in a lot of cases with just a single stent.
And if you go on history, we didn't see the RCA clip. If this LED is well polarized, I don't know what was the level of polarization. Then the question remains whether the culprit vessel is LED or the diagonal itself. So that's another issue, that if this LED is subtotal or almost local section, half flow, and you have this diagonal and the patient is coming to patient, it's hard to imagine the patient is having 2 weeks with this LED, pulsating line, everything, things like that. If this LED is polarized from RCA, the question remains that for this event, is the culprit vessel LED or the diagonal?
She had unstable angina, 2 weeks history of unstable angina, despite optimal medical therapy.
I would like to see more views so that the length in diagonal as well as the segment proximal to the bifurcation, because we are planning for decay crush and there will be a lot of work proximal to the bifurcation. So if there is not a pot segment available, so it's better to do the provisional rather than going for the decay crush. So I would like to see some other views, lengthening views, aerocranial, epicranial. So because yeah.
You know, there's a very common thing in Forge that you can't have enough groups. Whatever happens, you need more groups. So you want more views. So you got the views here, you got to make a decision. My question is further to what Saqib Saab said, that this guy comes to us with a 3-week history of stuff being done. Now, like you said, suppose this LED was closed many years ago, and now the syndrome is coming from this large band. Is there some way of deciding it?
You know, when you see an LED which is closed, then the segment we were saying, there are some questions about it. But actually the question is, how is the distal LED? What is the condition? We are not seeing it. So the right coronary injection is very crucial in such cases. You see the right coronary itself, but you also see whether it is filling retrogradely or not. If it is not retrogradely filling, then an MRA or something like this will help you to see the condition of the distal LED. Because if you open this and then you find the whole LED is diseased, then you also have to find out what the condition of the myocardium. Is it viable? Is it not viable?
So I think we have
this
ample.
is why, you know, I agreed with Dr. Bashir Hanif that he said that, you know, this lady already had STT changes on the ECG. So when you do a stress test, you don't have to have an ECG done, but either you have to have an echo or a therium to see the myocardium. Is the myocardium is viable, or is it a scar is already at the apex? So I think, you know, with just this thing, deciding for a 60-year-old lady, class 3 angina, I think is not justified. With this one view, to do something about it, I think is not justified. The whole patient should be dealt, myocardium and the distal LED, how it is. And, you know, I think the right coronary artery injection is more important to see than the proximal LED. The question is the ostium of the LED involved in this process or not?
So I think we've spent more than 2/3 time on this discussion, and the questions which are, do we need to visualize the distal LED? So one, we should have probably run the whole angiogram and just played it as any operator would see those 6-7 views and then make a decision rather than showing these selected clips. So right view, certainly it comes in very handy to tell us. But we do know that in acute syndromes, acute MI, the distal contralateral filling sometime initially is not there. So you may not be able to visualize, and if you do not visualize, do you stop an intervention? Do you go for another procedure to visualize the distal with MRA or a CT? These are questions which are there. The question is still there that which is the culprit vessel that, you know, an ECG, if you had shown us an ECG, that would probably have been more useful. And then, sir, we need to get on with the technique also. And so I just want to see what the question which came up here. And then, of course, one little fine, most of us would want to keep it provisional, which is fair enough. And everybody has own way of keeping provisional, like dilating the side branch and then stenting, or stenting and then recrossing and doing a case and seeing what the flow is like. I'm just trying to go over those points which I gathered from this conversation. So we have got less than 20 minutes now, and we can talk about the technique of DK crush. So if you don't mind, let's go to DK crush now, because there's so much more to talk about DK crush, and then we, need to understand the technique. Otherwise, they will not make at least me the moderator next time. So for my sake, we need to get on the technique. Let us get on with.
Actually, it is because the tips and tricks regarding the DK crash. So how to plan it? Two important things, as we have discussed extensively about the angiographic assessment, and second should be about the arterial access and guide selection. So we can discuss, as we have decided, two stent strategy. So how we select the guide.
So
and,
let's just show hands
access.
and move on.
Yes.
We all have opinion. So how many would use a 6 French guider, and how many you would use a 7 French guider? So hands for 6 French guider. Okay, hands for 7 French guider. Okay, radial axis. Femoral axis. Okay, well, I think radial really would be an advantage. There's less bleeding, and if you can use a balloon at the tip, you can do a sheetless entry with a 7 French, and it's really never an issue. In fact, if you have a spasm in your radial and the catheter is not going, it's not a bad idea to put a wire and a balloon at the tip and take it forward, and that really comes out. And if you get a spasm, put in propofol, diluted, really relieves the spasm very effectively, and it's a good way of pulling a stuck catheter out, you know. Okay, so we have decided that we're gonna go radial. Most of us would prefer a 7 French, because you can do a crush or whatever with a 6 French, but does make life a little easy if you're using a 7 French. And if you can do, I've done sheetless entries from the groin with a 7 French guider. It becomes a little tricky to manipulate, but and you just need a 6-inch sheath. So you just take the sheath out, put a 7 French catheter, pull it out, and put a 6 French sheath back in, because the complication with 7 French sheath invariably becomes a bit more tricky. Because you know, Dr. Rosny said your hour will just run away, so don't think it's a lot of time. And I think he's been through these things a lot, and he knows what he's talking about. So I think we'll try and keep this thing going.
As you all right, the radial was done, and the diagnostic was done through radial 4 days back. Then it was discussed with the surgeon, but they opted for PCI, so we started with femoral. We decided 7 French XP. It was 3 because the lady was short, so we decided to take 3.
Anybody would want to take a Judkin here rather than XP? Okay, so the Judkin, this XP support is God's gift to the interventionist for the left side. But right side, we have a lot of problem with the right choice of guiders. Okay, so we've crossed. So what are, at this point, how many would do a DK crush? How many would do a Q-lot? Now we're all on to a 2-stent strategy. How many would do a DK crush? No. Okay, you are not committing right now. But looking at the angles, the size of 2 vessels, I think we are on to 2-stent now. That's decided. So the choice of technique with the 2 equal sized, good angle, I see no reason why a Q-lot is not a good option. And it takes less balloons, less time, but basically on how you train. So how many would choose? So we are going to now. Sorry, let's get on with it. So what you've done?
Okay, so we have wired both the vessels. For LED, it was Whisper, and for the diagonal, it was BMW.
Okay, so you wanted a slippery wire for the LED because you thought it's a total occlusion. Although it's not a CTO, it's an acute syndrome, so it's possible that ordinary workhorse wire may have gone. So just a little loud thinking. But choosing a Whisper is fair enough.
Yeah, so the next, we are discussing.
And of course, a lot of people have different inventories. Somebody would take a fielder, another guy might take a pilot, depending on what you have. The costs differ at all, but it's all a question of getting used to your inventory. You don't need a huge number of wires. You need 5 or 6 wires in the lab, and you're done, you know.
So this was a straightforward, there was no difficulty in crossing the side branch, but we come across with the lesion in which the side branch is having, angle is acute, and we have difficulty how to cross it. So we can discuss if anyone wants to. Okay.
Okay, so we've dilated the LED, and we've crossed it to the diagonal.
So this is the algorithm for crossing the difficult side branch crossings. So it's either it is wire-based or microcatheter-based. We can change the angles, try to different wire, or pull back the hairpin techniques, or we can use the straight microcatheter with large wire curves, or we can use the angulated microcatheter of supercrossed 90 or 120, or we can use the dual lumen catheter. If the main vessel we are having calcification or difficulty, then we can think of atherectomy.
This case certainly doesn't look as if it's an atherectomy case. Looks like a neat and clean crossing. You need these micros if you have angulated vessels, different angles, you know. So this doesn't look like as if you're going to need any of these. Just to keep things going, because we're now less than 15 minutes going over with us, and we need to cover the whole DK crush.
So these are the various type of wire tip.
Next, please. I think we can carry on. Okay, so you've decided on a DK crush.
Yeah.
And you have now dilated the diagonal first. And you
diagonal was dilated already, and main vessel was
anybody
dilated.
wants to make a comment on why DK crush is suddenly becoming so popular? What's the big advantage of DK crush? Tariq Shafi? Okay, that's a very important point. You never lose the wire patency in DK crush. So if it's a tricky situation where crossing was difficult, then DK crush is the only technique which you should apply. In every other technique, you would lose wire patency, recrossing would be an issue. So it's a very good technique. If it's a precious side branch or the two branches, you don't want to lose anything, DK crush is the way to go. It just secures. Otherwise, in every other technique, there's a little issue about the side branch. You may or may not get it back.
So we have taken the stent, and one thing which is important, so we should know our stent. The stent in ostium we should take which has the marker, the stent along the marker, like Zines.
Can you tell the difference, please, in the markers?
Some of the stents has the space between the marker and the actual stent. So if we take it in bifurcation or ostium, we will unable to precisely place the stent. So this was, we purposely took the Zines because the stent and the marker has not a bigger space in
so
between.
the marker is in the middle of the stent is middle of the marker in Zines, and others it's a bit short. Does it really make a difference clinically to everybody? Does anybody take note of this, or it's just an academic discussion?
Then the Zines trying is that choice.
Okay, that's fine. So we dilated the side branch?
Side branch, both were dilated. We have placed one balloon which is waiting for to crush the. There is balloon.
So as you dilate this, you got the other balloon there also?
Yeah, there is balloon, NC balloon waiting for the side branch stent to be crushed. This is stent.
There's the stent going in?
Yeah, this is stent. We are seeing into our...
So important thing is, once you inflating the stent in the side branch, you must have a balloon beyond it. Otherwise, crossing it would become a real challenge. And so you have to have... and if you're using a 6 French, I would suggest put the stent in first and then take the balloon in. Because if you put the balloon in first and push the stent in, then there'll be so much little space that you will brush off the drug and lose the drug-eluting part of the stent. So if you want to do this on a 6 French, put the stent in first and the balloon later. Just some things to keep in mind. Next.
Stent and what size balloon are we using here?
In LED for the diagonal, the stent was 275/15. And in LED for crush, we have decided according to distal vessel diameter, it was 3.
And for crushing, which balloon will you use?
3 NC.
Anybody would want to use a larger balloon for the side branch? Both at 2.75? Okay, you can always make a 2.75 bigger, but, to me, crushing this with a 3 would probably be undersized, just my thoughts. You need to make sure that you crush it properly, otherwise your equipment's not going to go across. You got to really push it out. And once you know that you are going to stent it, it doesn't matter if you're oversized. You can oversize because you're going to cover the section. And the question about dissection, whether it's there or not, angioplasty treats by dissection. So when you inflate a balloon, the section is going to be there. So that is a presumption which you have to take, that every dilatation will be accompanied with dissection. That's how angioplasty works.
So one question which is being asked oftenly, whether we should leave the wire while crushing the side branch stent.
Okay, the question is, once you've crushed this side branch balloon, do you keep the wire in or you take it out? So there's no reason to trap the wire in.
So,
I, by design, never take out the wire. I only take it out after I've recrossed with the other wire, dilate it, and then I take it out. That's just the other extreme. How many would want to keep the wire in while crushing the stent? Okay, and how many would want to pull the wire out while crushing? So about equal. So we all differ, which is fair enough. I think it may help you anchor and get the balloon in. You know, I mean, of course, you can't miss it now that you've crushed it, but the theoretical of some way losing it. And the big advantage is I once was doing a decay crush, and I could not recross the stent, the crush stent. I tried everything, I ballooned it, I changed the wire, I couldn't recross. So what I did was I recrossed through the jail trap balloon, the wire. I opened it up, and I opened the whole stent again, and I turned it into a culotte. So if you keep the wire in, you can turn a decay crush into a culotte if you leave the wire in. It's because for every bifurcation, one needs to have a backup strategy. So that's my backup strategy. If I have difficulty recrossing, I'll just open it up and turn it into a culotte. So we have less time now. Let's 7 minutes. Okay.
As majority decided, we also did the same. We kept the wire while crushing the side branch stent.
Just a small point. If you want to jail a wire, never jail the black portion. You must jail the hard portion. If you jail the black portion, it is all threaded together. If you pull it, it'll open up like a thread. So never jail the black, small, soft portion of a wire in a stent. Always jail the hard portion because you might break your wire. So that's something very important, you know. So like we are seeing something here, we deliberately kept it here for this point. Never jail the black portion or crush it, trap it. It should be the hard portion. Okay.
Why we should cross the side branches after crushing through proximal struts? Why not distal?
Okay, 30-second. Anybody has any choice about distal and proximal crossing?
Dr. Shaf,
the crushed distal cell will leave the carina uncovered with the
But for distal vessel, you tend to cross distally. And it's for left main where you need to do a proximal or a mid crossing. Because if you do a proximal crossing, there'll be so much lump of metal going across the LED that becomes a mess. So I think a middle crossing is what I would prefer if I chose.
I think my question is, doesn't it depend upon the bifurcation you are dealing? If it is left main, LED and LCX, and whether it is LED and diagonal, if you are want to cross a wire into the side branch from the proximal and distal, my point is, if it depends upon the bifurcation you are dealing, or you are asking that it should be the default strategy?
We are asking about the crust.
Yeah, so if it's a distal crossing, like a diagonal or something, or do a distal crossing. And if it's a left main, you do a proximal or a middle crossing.
So if you read the European Bifurcation Club guidelines, it very clearly states that you should deal all bifurcations in a similar manner. So apart from crush, mini crush, decay crush, all of the techniques you should cross distally. And only for crush, mini crush, decay crush, you should cross proximally to allow proper carina coverage. And that's the European Bifurcation Club.
Great, excellent.
Except if the angle is very narrow, then we can cross it a bit distal as well. Otherwise, in crushed and decay crush, as Dr. Umar said.
Let's go on. We have less time.
So, if we cross it, the wire distally.
Yeah, we've covered this point. In the interest of time, we will just move on.
So what
We just
happened
discussed
as
this now.
Dr.
Yeah, yeah. Okay, we have to finish at 8. Okay, the big question, if your balloon doesn't cross, you've crossed the wire and the balloon doesn't follow. Any suggestions? Quick tips and tricks, Sir Shafi? If the balloon doesn't track over the wire, once you've crossed the wire, recrossed, and the balloon doesn't go, what's happened?
Then you should recrush it with a bigger balloon.
Okay.
And try a different cell.
Okay, try to recross.
Yeah.
Yeah, okay. So by and large, try a smaller balloon, get the angles right, get a good support, use appropriate. Some people try and recross the 2.5 or 3
and
balloon.
To prevent it, you should dilate the osteo part of the side branch stent with a bigger balloon, say 308.
Yeah, and another thing is, if you're recrossing and you're twisting your wire, it will wind around the first wire and the balloon will not track. So when you're recrossing, just do a 180-degree turn, not more. And then otherwise you will entangle the two wires, and that's one of the biggest reasons why the balloon doesn't track, because if you've recrossed properly without the wires getting entangled, then you need to recross. And if you have a 7 French, it is more forgiving. 7 French allows some re-entanglement to be crossing becomes easy. So that's a very valid point. And if you are like pushing with a balloon into a side branch, you can anchor the catheter with the inflation in another side branch if you're crossing a lesion and push harder in a CTO, but one should not probably do that with a stent, because you might deform the stent if you're not properly, if you're under the struts, you might cross, but you've totally deformed. So crossing the side branch, normally, if you cross properly, is a very convenient way of going across. It's not a big deal. It's not a...
Three things you can do very, very quickly. One is when you put in the stent in the side branch, use a stent balloon to flare the ostium of the stent, high pressure. Number two, what you can do after that is a modified DK crush. You can take the stent balloon out, put an bigger NC balloon, and then flare it even further. Third, after crushing, your balloon's not crossing. The Japanese balloons nowadays, especially Ryogen, is very, very good at recrossing into crush stents.
Next, please. We got like less than 2 minutes, sir. I think what's happened, okay, let's please go.
So we took a low profile balloon 1.2 into 15 and sequentially dilated with bigger balloon. Then did the first case.
Sir, we got 2 minutes, so let's quickly go through this and if we have got some real points, because I think Dr. Rosdi was so right that the hour will run away so quickly you won't even know.
So 1 point after crushing and kissing, my stent was not going through the main vessels. So we had to image it and further crush it with larger balloon. So in this case, I took...
Aage chale?
So you have not done the proper first kiss. So that's the reason. So improper first kiss can obstruct the main branch stent movement.
I think that the main branch balloon was undersized. If it was proper size, we would have crossed the...
Yeah, because we have decided...
1 minute to conclude the session.
We have decided the main vessel initial for the balloon for main vessel, according to distal vessel diameter, it was 3. So then we were having difficulty in advancing the stent, so I have to crush it. But the crush, pod crush, which is called, it should be proximal to the carina, as in this case.
Yeah. Sir, maybe we should come up and fast track this a bit so that we can finish the whole beautiful procedure in...
Okay. We could cross the stent, we inflated it.
So when the stent did not cross, we inflated with a larger balloon and then the stent went properly?
Then part. So here.
It's good. Sorry? Can't see?
Because they have stopped it from, I think, here.
Beta, क्या हो गया?
नहीं.
Okay. So what's happened is कि वो time bar हो गया, so हमारा time खत्म हो गया. So
Started late actually.
it doesn't matter. So it is that like we put the second stent in, recrossed, we did a kiss, and after that appropriate kiss, we then did a final pot. And the result was actually excellent. Can you show the final result? And they will not show it here, but
Can you show it?
इसको चलाएं.
Why don't you bring your laptop here in the middle and...
इसको बता दो. एक मिनट. इसको
Connectivity.
अगला दिखाएं. अगला
This is the
दिखाएं.
last.
Okay. इसको चलाएं.
This.
इसको चलाएं. Okay, इस पे फोकस करते हैं बस. This is the final result. लेकिन तस्वीरें बहुत अच्छी नहीं आई. इसको फोकस करें. इसको इलाज कर सकते हैं?
नहीं, यहाँ से.
Okay, this is. Can you zoom this, please? Can you zoom this, please? इस पे zoom कर सकते हैं? इस पे zoom कर सकते हैं? It doesn't matter.
थोड़ा पीछे ले आएं.
So it doesn't matter. I think because we could not time manage this very properly, so we had to rush through something. We spent too much time on the clinical aspect. Ji Sharam sir.
Place it proximally across the stand that, while we are deploying the stand inside.
It's easy to pull it back. You can pull it back, but if you want to put it across, that's perfectly fine. Makes a little difference. But the thing is, you don't need to recross. If you do, then you'd have to use smaller balloon. And any pressing comments, sorry for the mismanagement of time and not talking through the procedures. Any last comments before we leave, because they could start the session there.
Sir, in the start, a comment was made by Dr. Tariq Shafi. I want to ask, is not it depend upon
Can you identify yourself? Can you identify yourself, please?
Sir, I am Dr. Zain Mahmood Bhatt. I am from Wazirabad Institute of Cardiology.
Oh, wonderful.
Ex-fellow NICVD. I just want to ask a question from Dr. Tariq Shafi. He just mentioned that before deciding if he wants to go for DK crash or not, he wants to see the proximal segment. For me, it depends if the size of the balloon you have, like if you have shortest possible balloon, if it's 8 millimeter in your lab, you can go for it, keeping the view that proximal segment is healthy and you can place your stent. I want to ask what specifically he was looking, because I want to know his experience.
So what the good doctor is saying is that when you want to decide about how much stent to pull back, you decide that with the pot balloon. Yeah. If you have a short pot balloon like 15 millimeter.
Yeah, 4 millimeter is also available.
Yeah, and of course there are.
Not in Pakistan.
No, but the thing is what you have in your shelf, that's important. Yeah. So you got to work out your shelf. So if you just pull back 8 millimeter and your pot balloon is 15 millimeter, then you're going to have a disaster. So you got to work out your pot balloon in your lab on your shelf. We don't want to know what the world has. We want to know what's on your shelf. So when you take on left main or DK crush, you must have the inventory right, look at them beforehand, because it's going to be disaster if you start a procedure to find out you don't have the right balloon.
So
if you have a short...
What was the size of the pot balloon in this specific case? Size of the pot balloon, length?
It was a 10 millimeter. That's how the procedure was. It was very appropriate. 8? Okay.
It was inflated in left main part of it. No?
It was inflated in the proximally just short of the carina. So I think that the time's beyond. We can talk as much as you want. Now it's all. Any comments? I think so Dr. Rosalie, any home take message for us?
Well, I think this is a technique which is still quite more difficult than the others. It has got its own merits. I think data is there, and as you clearly point out, that you actually try to preserve the side branch, so at least you know that the side branch is preserved before you go on and treat the main vessel. So the intricacies of it, I think you should still go through, and especially for the younger ones, the pot and final pot and so on. There's such a thing as a pot crush after the first stent. I tend to use a balloon as to the distal vessel. You'd crush, and then you use a bigger balloon, And this is to crush you pot crush, so that down you can actually make sure that the stent struts are against the wall, and then you carry on. So the pot crush is something a bit new in the bifurcation club suggestion. So otherwise, in the end, you need to make sure that both results are good, especially the main vessel, so that you want to preserve the flow as much as possible and get good long-term results.
Any other comments?
Just one little point for any fellows. I mean, as you know, the CDs travel around, and a lot of people like to do bifurcation, but European Bifurcation Club states that if you're unable to do final kissing balloon, that basically that is a failed procedure. So don't walk away thinking that, I've done an amazing case if you have not been able to do final kissing balloon, because basically you failed the case and the patient.
I think that concludes the session. Thank you very much. I think it's very useful for us, and we covered a lot of aspects. There's still a lot of teething questions, basic questions, and I think Dr. Rosley's comments that your 1 hour will fly away is looming very large on my, we should, there's so much to talk about in these things, so many comments, but thank you very much for a great session. It was very learning for me, and so enjoy the rest of the workshop.
So the session is starting next door, and they're all waiting for you. You are the only audience available over here. So better rush.
Yeah,
Thank you.